Hello and welcome to Coasting Country, the official podcast powered by the science of the Connecticut Agricultural Experiment Station. I'm your host, Brian Scott Smith. We've all been living with COVID-19 for months now and feel we've probably heard every story there is about it. But there are always new developments, and in this podcast, we're talking with Doug Brackney, a scientist at the station, about work he and a team of scientists have been doing since the coronavirus pandemic began. Doug, thanks for joining us on the podcast. You work for the Connecticut Agriculture Experiment Station. You have many hats, but we're today talking about COVID-19 and wastewater and also a new COVID-19 test for people. So explain to us what your role is in connection with these two aspects.
Primary hat has been studying vector-borne diseases, so tick and mosquito transmitted diseases. But when the coronavirus came and the pandemic started, a lot of the facilities started shutting down, the laboratories started shutting down, both the state and university levels, and they really started restricting the amount of research that could be done there. And they really limited it to essential research directed at finding either cures or diagnostic assays or understanding the biology, immunology of coronavirus. And so I was working at home, and I just felt this need to be able to contribute. I have expertise in virology and experience working in the laboratory, and I really wanted to try to, offer my knowledge and skills to the effort to work on coronavirus. And so I reached out to a colleague, Nathan Grubaugh at Yale School of Public Health, and I just said, hey, is there any way I can help? Because I knew that he had started early on working with Albert Koch and doing some genomic surveillance and early diagnostics for coronavirus at Yale School of Public Health. And so I just reached out to him and I said, hey, any way I can help, just let me know. He put me in contact with Jordan Pecchia over also at Yale, who's starting to look at wastewater treatment facilities and seeing if we can actually surveil and track coronavirus activity at a community-wide level by analyzing wastewater samples. And so that was sort of the first project. And then at the same time, when it came to the diagnostics of coronavirus early on, there was a lot of bottlenecks in the pipeline because it wasn't expected. There was only a handful of assays that were approved by the CDC and the FDA for detection of this virus. And with those FDA approvals, they're very specific. So you have to use this kit from this company and these primers, and everything has to be very specific. You can't have any flexibility. And so what happened is early on is that you had a lot of bottlenecks in the supply chain because there were only certain companies that could do it, and they couldn't keep up with the demand for producing these RNA extraction kits, for producing the PCR reagents, for doing all these things. And so one of the goals was to try to find ways that we can open up the market so that you can use products from these other companies that had plenty of product but weren't certified as being part of the or weren't validated to be part of the diagnostic assays. And so that was sort of a second project that came out of what we were doing.
We're going to get into that second project in a while, but let's get back to this one with regards to you're working with Yale and the COVID-19 and looking at wastewater, because we've heard many stories as COVID-19, for the past several months has been on the lips of everybody, of course, and every media outlet that there is. Explain to us what this is about, because this is interesting and intriguing.
So for those who may not know, coronaviruses are a family of viruses, the Coronaviridae, and there's a number of viruses that actually regularly infect humans, circulate within our population, and cause a common cold each year. And previous studies have shown that you could actually detect these other coronaviruses, these ones that just cause the common cold. You could actually detect it in wastewater, along with a number of other pathogens such as norovirus or poliovirus and stuff like that. So there was ample evidence that you could actually detect these pathogens in wastewater. The first goal in our hypothesis, and we thought it was pretty sound, was that if you went into the wastewater treatment facility and tried to detect the novel coronavirus, could we do it? And we were pretty confident that we'd be able to do it based on the previous studies of other coronaviruses. And so that was the first step, was just going out, trying to optimize our protocols, streamline them, and identify whether we could detect it. And so that was really the early stages of the process, just getting samples and going through different ways of how we were going to extract the coronavirus genetic material, which is RNA, and then also then how we were going to detect it if there was potential. And then once we kind of got going and we were able to show like, yes, we can detect it, Jordan really had the foresight to be collecting samples, daily samples from the New Haven wastewater treatment facility, and that started on March 19th. And so this was really at the beginning of sort of the uptick of cases in New Haven County. We had at that time we had already started seeing quite a number of cases in Fairfield and New York City, and it was just starting to make its way up the 95 corridor into New Haven. And so it was right at the beginning, as case numbers started going up, that we started collecting daily samples, and we've been collecting there ever since.
So let me ask you this. Why was it important to do that, other than the fact that you wanted to see, as you said, if you could, and you worked out that you could do it? What did it actually reveal? What did it help us with by way of knowing how coronavirus was active in the area?
So yeah, it's more than just just saying like, can we do it? So the goal of this was to be able to see if we could use it to get an idea of the community-wide burden of coronavirus. So on an individual basis, you can get a test and you can be determined whether or not you are infected or not. But early on during the pandemic, tests were not readily available. It was hard to get the test. Oftentimes, your results would be, you want to get your results for a week or more after you had your test taken. And so, to really try to get an understanding of how wide and how many people were infected in the community, we thought that this would be a good proxy to understand how much activity was occurring. Because in addition to those people who are symptomatic and will go and get tested, there's also a large number of people that show no symptoms or very mild symptoms and may never get tested or can't be tested. Especially early on when there was a limited number of tests, they really winnowed down who was going to be tested and who wasn't. It was really hard to understand how big of a problem it was in New Haven County. And so the idea was, if we can look at the amount of genetic material of the virus in the wastewater and quantify how much genetic material is there, that should be a good proxy for how widely distributed or how wide the pandemic was affecting sort of the New Haven community. And so that was really the goal, was to see, okay, with the way that the individual testings were going at the time, limited number of tests and not everybody being tested, we didn't really have a good understanding of how widespread it was in the community. And so this was really what we were trying to do with this study, was to get a better understanding of that.
And I'm sure there's a lot of data because, as you said, you started doing this way back in March. I mean, what did it start to reveal once you were looking into it and you were extrapolating results?
The big findings that we got from this, it was really impressive. We started working with a number of people at Yale. They were able to take our data, and what we could see is we can see on a daily basis that the amount of coronavirus genetic material in the wastewater was going up, and it came up and had this nice sort of peak, bell-shaped curve type of peak. And then what we did is we actually then mapped that back to the number of cases that were being reported in New Haven County. And then we also mapped it back to the number of cases, of hospitalized cases, so how many people were admitted to the hospital. And so when we actually did that and doing some mathematical modeling, we're actually able to show that surveilling the wastewater acted as a leading indicator of the amount of cases that we were going to be seeing, both the number of cases diagnosed and the number of severe cases that are hospitalized. And so specifically with hospitalizations, we found that it was a leading indicator by about 3 days. We were detecting an increase in coronavirus genetic material in the wastewater 3 days prior to an increase in the number of hospitalizations. And that this also, when you looked at it as the total number of just confirmed cases, we also saw that served as a leading indicator anywhere from 2 to 7 days for the number of confirmed cases. So at the end, really what this study showed is that you can actually look at the wastewater and get sort of, you're sort of looking into the future, but also it gives the public health officials to implement strategies to help curb. So do we need to introduce new restrictions, or do we need to go to online schools, doing these types of things, you can then sort of adjust what your public health policy is and how strongly you need to address something based on this data prior to a lot of cases. So it gives you an earlier warning sign. And so that's really the power of this study.
Which is absolutely amazing, because I'm assuming any sort of like advanced warning or any sort of like advanced notice that you can get when you're dealing with, a virus or a pandemic must be so helpful, in so many situations. Obviously, it was helpful for Connecticut. I mean, is this process, is it going to be rolled out beyond Connecticut, do you know, or has it been rolled out beyond Connecticut?
I know other places are doing this to a degree, but there's different ways you can collect this wastewater, and we're really collecting it at a point in the processing of the wastewater where a lot of the solids have sort of sedimented out and they've settled out, and so we're actually able to go there and take a sample of this more solid phase, which is called the sludge, is the primary sludge. And by doing that, you really are sort of concentrating everything in the community into a single sample. And a lot of other places that have started implementing similar strategies, and there are some private companies that are actually doing this, is they're doing actually the wastewater. So this is the wastewater effluent. So this is what is running through the wastewater pipes as it goes to the treatment facility. So things haven't settled out. Within that, you have all of your dishwater and shower water and all this other water that gets in there. So your samples gets very dilute in there, and it can make it challenging to consistently detect, I guess, quantifiable levels of virus in the wastewater. So, one of the things too is by our study was we were showing that really primary sludge was a very good source of material compared to just sampling the wastewater effluent. So I know other places are starting to do it. We have in Connecticut, we've just in the last 2 weeks, we've gotten some funds from the state to expand our current efforts. So we've continued doing this through the whole pandemic since March 19th in New Haven County, and we're in contact with Mayor Elliker weekly about what our results are showing. But we've just recently expanded it to other sites, including Bridgeport and Hartford, New London, Stamford, and so we're expanding to other treatment facilities in the city where there are larger urban hubs. Because obviously, a lot of Connecticut has a lot of semi-rural areas where a lot of people are on septic systems, so we can't actually get everybody, but in these larger urban areas we can definitely apply the same technique, and we just started rolling that out in the last last week really.
So basically what you're doing is you're hitting the centers which have been hit the hardest, here in Connecticut, New Haven County, Hartford, all of those areas really have been sort of the hotspots for COVID-19. So it makes sense that you obviously target those areas.
Right. Yeah, exactly. That is the key goal. So, yeah, we might be missing a large area of the state due to lower densities of the population, but most of the activity, like you said, is in these urban environments. You can see this repeatedly from state to state all over the world. It's the big urban environments that are really driving this.
Now, another thing, of course, we mentioned it at the top of this interview, is this new test. It's a saliva test. Explain to us about that, because there's been a lot of press about it lately.
Right. So, early on, the diagnostic test and the sampling for coronavirus was done through what are called nasopharyngeal or MP swabs. And, this is a process I'm sure a lot of listeners have seen this done or had it done themselves now, with this long, sort of skinny swab that they stick up your nose, all turn it around a couple times. And a lot of people find this very uncomfortable and irritating. And so early on, it was showing that these MP swabs, the diagnostic test that was done, so this PCR approach, was actually very accurate and very sensitive. Problem was they had about a 70% detection rate when doing MP swabs. So about 30% of actual infections were missed by doing an MP swab. And really this had to do with how the samples are collected. So, you really have to have somebody that is a trained health professional acquiring the sample, and everybody has to be trained similarly, and they all have to be done properly in order to get actually a good sample from the MP swabs. And so while if you got a good sample, it could be very sensitive, it's good, but there was a lot of variability in how the samples were collected. leading to this 30% sort of false negative rate. A woman at Yale, Ann Wiley, working with our group down there, she started looking at saliva, if you could use saliva as a good diagnostic. And what she found is that saliva is actually just as good, if not better, than nasopharyngeal swabs. The advantage of just doing the saliva is, one, it can be self-administered. You don't have to have a professional healthcare provider taking the test. And it doesn't require any, it's not uncomfortable, or it's not invasive at all. It's pretty, just spit in the tube. And so having this sort of data that Anne had generated, we then wanted to take it to the next step, saying, okay, as I discussed earlier in this podcast about these supply chain issues that we had, we wanted to see if we can actually streamline this and sort of get rid of some of the steps and some of the issues with these potential bottlenecks, and develop a new assay that we can actually just take saliva, do a short little treatment with an enzyme that is you can buy from many, many vendors, and then heat it up for 5 minutes, and then actually put it right directly in the PCR suite. We're getting rid of that RNA extraction step, and that's probably one of the most expensive parts of this process, is actually doing the RNA extraction. So if you can get rid of that, you're removing one of the steps that's expensive, requires trained professionals to actually do that, and also relieves and removes another potential bottleneck within the process, as far as time, as far as resources. And so the idea was then to, okay, can we validate taking saliva directly, not doing an RNA extraction, and testing this with multiple different PCR kits, different PCR machines, the enzyme I mentioned earlier, which is proteinase K, trying it from different vendors. The goal was to try to make this, to validate this assay with as many different vendors' items out there as possible, so that when people started using it, they weren't relying on any one company. You wouldn't have price gouging from any one company. And so that was the goal, was to try to streamline everything, shorten the processing time, shorten how it's collected, or not really having to rely on trained healthcare providers, and really trying to make it more egalitarian as far as which resources and which reagents can be used.
How much more accurate is the saliva direct test? And more importantly, what does it actually tell you? Does it tell you that you've got COVID-19 or that you had it?
This is a test that will detect whether or not you have it currently. So this is looking at the genetic material, and this is not an immune test to look at whether you've developed immunological response or antibodies to the virus. So this is if you are infected. As far as the sensitivity is concerned, we found that it's highly sensitive. The idea is if you go to the hospital and you're sick, an NP swab is probably the option for you. Okay, that's probably going to be your best option, or doing saliva and going through the full RNA extraction. Either doing an NP swab or saliva with the full protocol is probably your best option if you are sick. The idea with this is to try to develop it to do rapid screening and large-scale community-wide screening to help be able to identify those who are maybe pre-symptomatic or asymptomatic, so without symptoms, so that they can quarantine early on people who might not meet the criteria needed to acquire a test. And so with that, we do lose a little bit of sensitivity compared to doing the full RNA extraction and assay. But we can significantly increase the number of people tested at a much lower cost. So that's really the advantage of this.
And I suppose as we see potential for schools reopening and things like nursing homes and even sort of like prisons as well, where we see inmates getting COVID-19, this sort of lower cost and, as you say, more rapid testing, I'm guessing is going to be beneficial for those environments where you've got larger groups of people.
Oh yeah, exactly. I mean, that was the idea in mind here. And so that's really what we're trying to do, is say, how can we make this so we can do testing for population screening as opposed to really looking at individuals who are infected. So exactly the target, what we're looking for.
And how can people get this new test?
Right now, I mean, this really just came out. The FDA approval just came out. One thing that this test is not, it's not a kit. It's not like you have to order it from us or get it from us. This is a protocol. So, one thing about being in academia, in this case, we're not trying to make money, right? We're not trying to develop kits and sell them. This is a protocol that we hope to distribute to all certified diagnostic labs that want to use it. And one thing that we're trying to do is set up right now with the legal department at Yale is that if people are going to use this protocol, that they cannot mark up the price. We're really trying to keep the price down. So if people want to use the saliva direct protocol, which is FDA approved now, they have to agree to not mark up the price above a certain percentage. It's a very small increase. And so right now we're trying to, we're working with the legal department and everything at Yale. There's a lot of behind the scenes stuff that I'm not even involved in, trying to get this so that we can roll out this protocol and get it distributed to places that can use it. I don't know what that timeline is. It hasn't started yet, although we've had 1,000 inquiries already about how do they get this protocol, how do they go about getting started and started doing this.
So I guess that the fact that it got emergency FDA approval means that once all of those things are worked out that you've just been talking about, that this test will go across the nation.
Well, I mean that is the hope. I mean, you never know. I mean, things come out and there's a lot of buzz about them at the beginning, and then they kind of go away. But that is the hope. In the coming months, that universities and prison, just communities as a whole, can start taking this protocol and using it out there. And so time will tell how highly it is adopted and used within our nation's plan, or if it's, internationally adopted.
The fact that there is another test and another way for us to help detect COVID-19, however widespread it goes at the end of the day by way of a protocol and who uses it, the fact that it has been developed is incredible and just an extra tool in the toolbox, isn't it, for everybody as we continue to live with COVID-19. Doug, it's been a real pleasure talking to you, and obviously a huge amount of work by yourself and obviously a team of people as well. As they say, it does take a village. And thank you obviously for sharing this invaluable information about these unique insights. Science is important, and fortunate to obviously have great scientists here in Connecticut. Thanks again for talking to us.
Thank you, Brian. It was a pleasure talking with you today.
And you can find out more about the work of the Connecticut Agricultural Experiment Station at their website, ct.gov/CAES. And if you want more information about the COVID-19 wastewater project or Saliva Direct that were discussed in the podcast, then head over to the website covidtrackerct.com. That's all from this edition of Coast and Country. Thank you for listening, and we'll be dishing up another serving of science for you very soon.